Alrighty, and we are live.
Good evening, everybody. Hello, and welcome to our healthcare town hall. Really excited to join you this evening. For those of you who don't know me, my name is Cameron Webb. I'm an internal medicine doctor and lawyer and professor at the University of Virginia, and also the Democratic nominee for United States Congress here in Virginia's 5th Congressional District. And this evening, we just wanted to create a space for the next hour or so to just talk about healthcare, the challenges that are facing our healthcare system, which is a huge part of our society. It's $3.6 trillion as a sector. It's 1/5 of our economy. It's the largest employer in terms of a sector in the United States. And it's a huge part of the challenges that folks are facing every single day. And for me personally, of course, I see this from a couple of angles. I certainly see it as a practicing physician, but I also see it in my policy work, and I see it on the campaign trail here in the 5th Congressional District. So I'm really excited to share with you all some of my views and my perspective, and just have a frank conversation about what the future of healthcare looks like from our current vantage point, and some of the policy levers we can pull to sharpen it, in my own personal opinion. To help shepherd us along in this important conversation, I'm joined by the illustrious Dr. Esther Chu, one of my favorite doctor communicators, particularly on social media, just a leading voice in this space to help moderate this conversation. And this evening, what we wanted to do is make this as interactive as possible. And so we want you all to be able to drop your questions. We'll have a link that's available to you. We've been spreading it on social media, but it's a link for you to submit your questions. And then for everyone who's participating, you can upvote or downvote the different questions. So that way we're always prioritizing the questions that you all want to hear the answers to the most. But before we jump in, I want to give a proper introduction to Dr. Chu. Dr. Chu is a physician and also has an MPH. She's an emergency doctor who completed her residency at Boston Medical Center, and she's in her health services research fellowship at Oregon Health and Science University. She's an associate professor in the Center for Policy and Research and in the Department of Emergency Medicine at OHSU. Her research focuses on women's health, intimate partner violence, substance use disorders, and technology-based interventions. She's past president of the Academy of Women in Academic Emergency Medicine and the recipient of the Society of Academic Emergency Medicine's Young Investigator Award. She also serves as the associate editor of dissemination for the Journal of Academic Emergency Medicine. Of note, she's co-founder of Equity Quotient, a company that provides metrics of healthcare culture, and a founding member and strategic lead for Time's Up Healthcare. So you probably know my good friend, Dr. Lauren Powell. And then she also, it's an initiative of the Time's Up Foundation, which advocates for safety and equity in the healthcare workforce. Her published work on gender inequity and sexual harassment in healthcare includes pieces in the New England Journal of Medicine, JAMA Internal Medicine, The Lancet, the British Medical Journal, and Harvard Business Review. And for those of you keeping score, those are all really high impact factor spaces. So really a known voice here in the healthcare space. And I'm so grateful that you would join us for this healthcare conversation this evening. Thanks so much for joining us, Dr. Chu.
Well, it's a total pleasure to be here. I feel like we've been in similar spaces for a while. And I have to say it was, I think a little over a year ago where somebody mentioned your name and said, you have to check this guy out. He is for real, and I felt, I often hear names of people who are kind of rising stars, but I have to say every time I've taken a look at what you're doing, it's just been more astounding and impressive, and following the trajectory of your campaign has just been really exciting and galvanizing and gives me so much energy. And that was way too much time on me. So let me try to match that and introduce you, since that's why everybody's here. So Cameron Webb is both a doctor and a lawyer who has spent his career addressing health inequities in our society. He grew up in Spotsylvania County in Virginia. His mother was a public school speech therapist, and his father was an HR manager with the DEA. And they really instilled in their 4 kids the value of taking an active role in community, and also the necessity of serving others. He graduated from UVA, then got his medical and law degrees, a double nerd here, and then was selected for a White House fellowship and served in both the Obama and Trump administrations working on healthcare policy, prescription drug pricing, economic opportunity, education, and lots more. As a practicing physician, he treats patients as a general internist, teaches students, and serves as a director of health policy and equity at UVA School of Medicine. His wife, Dr. Leanne Webb, is a fellow emergency medicine doctor who grew up in Appomattox County. They live in Albemarle County now and raise their two kids, Avery and Lennox. So Cameron is running for Congress to serve his community in this critical time for healthcare. In Washington, I know he'll be a fierce advocate to ensure opportunities for health and success for all Virginians. And as a very rare healthcare professional and health policy expert, he will actually be a positive influence in Congress for all Americans. So we have a number of questions from people, from the public that we will ask. I'm just gonna, and also please feel free to put your own questions in the comment area wherever you're watching, and we will try to pull those into the discussion as well. But since I mentioned that Cameron's a parent, and I know you and Leanne are also doing the school from home thing, and I just wanted to start by asking how that's going for you in this very odd school year.
It is a very odd school year, and I think the coronavirus pandemic, it's hit us all so hard. And I think we are all using a lot of caution. We want people to be safe, and we know that safety looks like making smart decisions along the way. And so, I understand, I support that our school system decided to open up virtually and have kids in virtual school. Avery's a 4th grader, and my son Lennox, he's starting kindergarten. So it was kind of sad to miss, that first day of kindergarten. But again, it's in the interest of safety. But, we're a little over a week into virtual school, and the degree of difficulty is significant, especially with the kindergartner. And so it's hard. And so my heart is going out to not only the teachers, but the parents and the kids themselves. This is hard for all of us. Some of the sacrifices that we're making so that we can keep our communities safe. But it's definitely tough. What we've done is, so I'm in my campaign office right now, but we've actually converted a conference room, and Leanne and I rent space from the campaign so that we have the kids in what we've turned into a classroom. So Leanne put it together. She's just amazing at the design and the layout. So it looks like a classroom. They're able to have their learning experience outside of the home, even though it's just the two of them. And it gives them a separate space so that home still feels relaxing and this still feels like school. So far it's going okay, but like I said, it's going to be a tough 9 weeks. But again, if it helps keep our community a little safer, then I'm here for it.
Yeah, and it's great to hear that you're a parent going through this exact experience, because I feel like there's something about this that leaves this indelible mark, meaning that we'll never again question the value of school teachers, and we will fight so hard to do whatever we need to end this pandemic, because because there's a particular burden with taking that on as well. So let's dive into some of the questions that came up in the preparation for this, all from people out there who wanted to know your take on these. So the first one and the most popular question is, what is your plan to lower prescription drug prices without harming medical innovation and advancement in the treatment of diseases?
Yeah, I love the frame of the question because it acknowledges a really important reality. As physicians, we both know that we depend on that innovation for our patients. We depend on it to save lives, to extend lives. And so it's really important to us. And you mentioned in the introduction, I worked in the Trump White House on prescription drug pricing. And so I've told the story often in my time in the Trump White House, but that was a space where the leadership in the Trump White House said, well, Cameron can work on this one because it's a bipartisan issue. We all agree we need to bring down the cost of prescription drugs. And at the time I was working with the now late Congressman Elijah Cummings, because he's really passionate about this as well. There's a lot that we need to do. And so there are some pieces that are already in motion. I think President Trump has said, hey, we need price transparency. We need transparency in how these prices are set. He'd love to see it tracking with international pricing. And I think those are ideas that have some merit. And then on the Democratic side, you have HR 3 that was introduced that has a lot of other elements to it as well, including some negotiation of drug prices. I think we have to start with acknowledging that in order to maintain innovation, we're one of the last innovators in the prescription drug space. In order to maintain innovation, the cost of creating these medications is significant. And so we have to make sure that the pharmaceutical companies can recoup those costs. And that looks like that period of market and patent exclusivity. They have to be able to recoup the costs. And I think there's a huge dynamic there where the public will see the sticker price of some of these medications and say, no way, that's way too much to pay, not understanding the billions of dollars that went into the development of the medication.
Mm-hmm.
And so here's where you have to understand the supply chain and the fact that insurance companies are a key player here, pharmacies are a key player. Currently, we have pharmacy benefit managers, and we have the manufacturers themselves. So there are a lot of different people who are impacting the pricing of these medications. You have to start with that end user. And so we say that for patients, they should not be absorbing the lion's share of this cost, right? They shouldn't be, no matter who you are, you shouldn't be paying, tens of thousands of dollars for your medications. And I remember being in the White House and having the Multiple Sclerosis Foundation come in and just talk about how the cost of every subsequent medication increased the price of the old medication. And that happened time and time again. So one of the things we have to make sure that we do is we say, insurance companies, you gotta, if you're insuring people's care, you gotta cover their prescription medications. And so we have to do some work on that front. But along those same lines, what we have to say is that period of time that you have patent and market exclusivity, that's when your prices are gonna be higher. But that has to end at some point in time. And there has to be a moment where we see generic drugs come to market. Based on the number of generics that you have, it decreases the cost of the index medication. When you have 3 generic medications, it decreases it to about 50%. When you have 7, it's down to a third of the original cost. That's a huge part of it. So here's where we lean into the FDA and their role in making sure that we can get generics to marketplace. We call it ANDAs. It's kind of the abbreviated new drug application, but getting those generic drugs to marketplace. I talked to a lot of generic drug makers, and they're just like, hey, we can do this. We can bring these generic drugs into this space if we don't have that pay for delay from pharmaceutical companies, if we don't have them withholding products that we can test against, because those are all loopholes that are making it harder to create generics. The Trump administration knows that, and they're excited to do work to address those kind of tricks of the industry. But that's not the only thing. What I was telling somebody just the other day was that we have to create a prescription drug pricing policy for the future and not the past. And in this era of biologics and biosimilars and billion-dollar medications, we just had our first medication that's going to be a $1 million medication, right? Like that's incredible, the cost of some medications, but it's the amount that we spend on creating them. So we can't there are some drugs that will never have a generic, and we have to understand that. And so we have to say, well, instead of you going generic, how about there has to be some point where your cost of your medication comes down because you kind of paid off whatever it is on that front end. And so I know that's a long answer. This is an incredibly complicated, policy space, but I think that understanding you've got levers in the FDA, you have levers in the competition space where we're making sure that we're getting generics to market. We have levers internationally so that Americans aren't the only ones paying the full cost of a medication, and that in some of our trade agreements, and this is something President Trump talks a lot about, other countries are paying their fair share, so it's not all subsidized by American payers. Insurance companies have to cover a little bit more. And then we have to have some regulatory change so that eventually those costs drop and things are available to individuals. And if we can do that, we have to thread a needle, because if we can do that right, we can preserve that innovation, preserve those new life-saving medications, and at the same time, we can make sure that for patients, the costs aren't going to be too high.
It's actually really good to hear you talk through that in such granular detail, because I think the reason we haven't made progress on it is because it takes some sophistication of understanding all these subtle issues. And it's nice to hear you so fluent on that, because this is really, it's a cross-cutting issue, and it is not partisan. I think something like 1 in 4 Americans do not fill the prescriptions they're given. Right. Simply because of cost. And those include Americans who are insured. It's just that there are, the full cost isn't covered. And I think that number is so stark to me. And it truly is affecting everybody's family member everywhere, no matter who they are.
Well, and can we mention just the cost of insulin, right? And I think that's such an important example.
Yes, thank you.
Because I think that's what brings it home for most folks in my congressional district is you can talk about these, brand new, monoclonal antibody medications, but then we're just talking about insulin. We're talking about something that's been around for a while, but there are only 3 major drug makers who make insulin, and those costs continue to rise. And I think that's where the American people look at that and they say, well, this doesn't work. And you see efforts to curtail those costs, like what happened here in Virginia, where there was a delegate who introduced a bill to cap that cost of insulin out of pocket at $50. And we're talking about capping cost. And President Trump proposed something similar through Medicare innovation in Part D, saying, hey, we're capping the cost for seniors on insulin. And that's a workaround, right? The reality is that what happened is insulin moved into the biologic pathway. So it's the whole idea of creating generics around it is different now. And we have to say, well, how do we get insulin more affordable? Well, it's something that every insurer should cover. And so the out-of-pocket cost is where insurers have a role to play in saying, actually, you're not going to feel any price increase in insulin. And then it's up to them to say, hey, what are some of the other options? There are a lot of ways we can get more insulins to market. And so I think that as long as it's been around, and so that's what we have to work on the regulatory back end. But for consumers, the insurance company is the one that's holding that line and can say, hey, you shouldn't be paying more than X amount. And there's a huge opportunity there. So that's your everyday, that's that medication that I think is top of mind for a lot of people.
Yeah, I mean, it doesn't get more basic than that. It's got to be one of the most commonly utilized medications. It's just shocking that it is that issue. And we've heard all these stories of people who literally die because they cannot fill their insulin. They start rationing and then just cannot afford the next month. And then they die of a diabetic ketoacidosis. So it seems like if we can't do it for insulin, then we can't do it for the fancier drugs.
That's right.
All right, so question number 2. Will your plan for healthcare get rid of my employer-based insurance?
So it's an interesting question, because I think when people talk about employer-based insurance, they're talking about what covers about 50% of Americans. And so employer-sponsored insurance is such a big part of the American health insurance experience. I'm gonna step back a little bit, take us back to World War II, and I'm sorry, I teach a class on this, so I can't help it. But in World War II, there was a freeze on wage increases, and so instead, health insurance was offered as a benefit to individuals. And I always say that that's the original sin of the American healthcare system, because what it did is it moved insurance into this space of employment. But what's interesting about it is that even with that, by moving insurance into that space, it became really problematic, because we tied people's healthcare to their insurance. So in terms of employer-sponsored insurance, I believe we should be getting rid of that bond between employer-sponsored insurance and people's health, or between employment and people's health insurance. So that's the first thing. But let's be clear, people's private insurance is given to them through their employers. So I will not be getting rid of private insurance. My plan does not get rid of private insurance at all. What it does is it gets your employer out of that game. That's why my plan for kind of health reform is very pro-business. Because when I talk to small businesses, they don't like the fact that they're in this space of providing health insurance to people. It increases their cost of doing business. It changes who they're able to hire. And I think from an employee standpoint, there's that concern about portability and that concern about the networks you have access to. I want people to maintain private insurance. I also want to increase access through a public health insurance option, so that way we're covering that 30 million Americans. But I don't think employers are the key to people maintaining private insurance. I think they can maintain that without employers involved at all. Now, here's the thing. If employers still want to use health insurance as a benefit they offer to attract employees, there's still a path for that. And it's called defined contribution. So employers can then say, we're going to pay X amount into your health insurance. You can choose a public insurance or a private insurance. But for employers, it creates some more predictability, because when insurance costs increase by 10%, 12%, 22%, like my last year and my year in the Obama White House, 22% increase on average in insurance premiums, and employers covered the lion's share of that. Well, that's where we say employers are like, well, I'm not subject to what's coming down the pipeline for insurance this year. They're saying this is the amount that I'm paying out. And then insurers are saying, well, I have to maintain market share. So how do I adjust the cost of that insurance? It does. I think that our work looks like making sure that in a design of a system that has a robust public health insurance option and maintains private insurance, we have to be careful not to create a two-tiered healthcare system. And you do that by making sure that what private insurance is able to offer is attractive to individuals, it's affordable, and your public insurance has to offer the full range of options, but at the same time, your private insurance can offer that range of options and some other pieces as well that are attractive to consumers. I think that when you put those together, that's our system at its best. And I think the private insurance space has been a great innovator in healthcare. I'm very adamant about the role of private insurance in driving innovation because we talk about the move toward value-based payment. And that is being driven by private insurance. That idea that you achieve healthcare outcome goals and you do it at the lowest cost possible. The leader of that is private insurance, and then Medicare followed suit. And so I love how private insurance has the opportunity to innovate. I also know from working in the White House that private insurers are ready for this version of the American healthcare system. They've been planning for it for a decade. So they know exactly how they're going to adapt in this space and still offer products that are attractive to Americans. And so I think it gives us the best of both worlds. We achieve that goal of 100% of the folks in this country having healthcare coverage, which is a basic requirement for folks to have access to care. But it also preserves choice, which is really important to a lot of Americans, and that they can pick if it's a private plan or one of the public plans. And I think that's kind of our best of both worlds.
I'm guessing as you talk to businesses, I'm so dialed down on what patients need, in underserved populations, but just listening to you talk, I'm guessing this message is one that's really appealing to businesses who have had to bear the cost, and there's no flexibility in there because they have to offer it. But it must be something that just sounds like such an opportunity for them to decouple themselves from something that's so necessary for their employees.
It definitely is. And I think it doesn't change the fact that there are other things businesses can still do. They can still have health savings accounts. They can still, invest in folks' healthcare in that way and say, hey, we're giving money toward your healthcare. That's something that I support, a very conservative idea. But at the same time, because people are always worried about, folks not having any skin in the game, so to speak, or moral hazard, as we call it. And the truth is, the data tells us that moral hazard, it leads to people deferring necessary care and unnecessary care when they're on the hook for their own care. So you can't depend on that solely. What you need to depend on is the fact that people are covered. It's safe for them to seek care because they don't have all the information they need to know when they need to go to the doctor, when they don't, when they have an emergency and when they don't. I know that sounds hard for some people to imagine, but you and I, we've both seen it. We've seen folks who are like, I didn't know if this was like a real problem. I don't want to overreact. And how often have we said, you should have come in earlier? I wish you could come in earlier, but we're going to take care of you now. We want people to have ready access to care. And I think that this is part of that, is making sure that people feel comfortable that whatever care they have, they can access. And I think that employers have a role to play by making sure that they're supporting the insurance that their employees have, but aren't on the hook for it. And I think that's important.
Yeah. That last comment you made rolls right into one of the other questions, which has to do with surprise billing, which is something that's been in the news a ton. You just show up for the care that you need. You go to the emergency department, and then you find that you didn't check in the middle of your heart attack or whatever it is. You didn't check to make sure that that was an in-network facility, and you get stuck with this huge surprise bill that is not covered as it should be. So the question is, what will you do to eliminate surprise billing?
Well, one thing that's interesting to me is that there's an assumption in the United States that Republicans and Democrats don't agree on anything in healthcare. And it's just not true. And I think that surprise medical billing is a great example of where Republicans and Democrats agree. There's bipartisan and bicameral consensus that we need to address surprise medical billing. And in fact, there's consensus even down to the point that patients shouldn't be on the hook for it, right? So everybody agrees patients themselves shouldn't be on the hook for these surprise medical bills, or you may call it balance billing. I think it's this idea that if you go to seek care and sometimes you find out that either a provider is out of network, or sometimes at no fault of your own, you are taken to somewhere that's out of network for your care, and then you are stuck with the costs that your insurance company won't cover. And as we know, the costs in healthcare are so incredible that nobody can bear those costs. So what I love is that Congress, both parties, both houses, both the House and the Senate have said, we want to address surprise medical bills. Where it's gotten stuck is kind of what piece of legislation are they going to connect this to? It's been part of the conversation for some of the COVID recovery funding, but it hasn't really made its way in. So it's unfortunate that we have so much gridlock in our politics because people are unwilling to work together, that we can't find a space to pass a bill that we all agree on, right? But I think that surprise medical billing, because there's consensus, I'll tell you what the consensus is around. It's a couple core concepts. And President Trump had an executive order that came out last year that said, here are the principles on which we're going to do work on surprise medical bills. And one of them was that patients aren't responsible. If you go out of network, no fault of your own, you're not responsible. If you didn't, hospitals and providers have to be upfront about, when you have elective care, about what's in network and what's out of network, so it's clear and transparent to you. And I think finally, if there's a provider who's out of network, then there's some pathway to address it. The key really with surprise medical billing is, yes, hold the patient harmless, make sure that they're fine. And then it's that negotiation. Here's the sticking point, that negotiation between insurance company and provider, right? That's where we really get hung up. And the different schools of thought tend to be that either it's going to be a price that's given to you, like a standard price that's set by the legislature in some way, or on the other side, it's a negotiated price, right? And I think the best version of it, and I've seen, several states, I think there's 16 states now that have passed, some kind of meaningful reform, because states are trying to take the lead since it's taken the federal government so long, but they passed some reform around surprise medical billing. And the conclusions that they're drawing, it tends to be that they'll set a standard rate, and then providers can essentially appeal it with a process where they get to negotiate that rate, right? And I think that hybrid approach, it's kind of the best of both worlds. It does allow some predictability in saying that, hey, no matter what, quickly the provider is paid that standard amount, but the provider can say for some reason, hey, that amount doesn't really meet what I need, so we need to have this dispute resolution process where I can make my case for why I need to be paid something different than that, that normal rate. And I think that tends to work for a lot of folks. I think it's our best path forward. The reason why we need a federal rule on this is because sometimes that out-of-network care is out of state. Sometimes that, and so when that's the dynamic, you have to make sure that, hey, there's a role. When you have laws that are in conflict between those states, it makes it a lot harder. I think that we have to make sure we're giving real guidance, and I think we have to make sure that this is something that's addressed quickly. Everybody agrees on it, and this is another thing that, unfortunately, it grew out of the marketplace. We didn't talk about surprise medical billing pre-ACA. It was not even a conversation. Right. It came out of the spot. I mean, the reality is you had a lot of investment, capital spaces that were like, hey, I can buy a practice. Our business model can be out of network care. And I think that's where it gets a bad rap, because it's like the business model is, well, we're not in network, but we provided your care, so we get that higher rate that we charge. We can work our way out of that. I'm glad this is one of those areas where we have consensus. And from my standpoint, it's where, having a passion for working with people who have different views than you is important, because you can say, hey, we all agree on this, right? So let's work on this together. And I have a relationship of working with you, whether it's on prescription drugs or whether it's on surprise medical billing. There are a lot of areas where we're able to work together, and this is one of them. But it's top of mind to folks all over the country, all over the Commonwealth of Virginia, and certainly in my district. When you say surprise medical billing, people are like, that's right. And I will tell you one last story. There's a gentleman who I was, I'm friends with here in our community, who had a veritable heart attack. He had a true MI and got a bill of $60,000 and had insurance coverage. And he asked me, he was just like, I don't understand how I can be charged $60,000 when I had a heart attack. If my insurance doesn't cover that, what kind of insurance is this supposed to be? And it was kind of that surprise medical billing space. And so, I think we have to fix that. We have to fix it quickly, especially in this economic environment.
Yeah. And talking with you, I know we're aligned on our views. And yet I also love how much you sit in this space of there's nothing but consensus around these things. We just simply, nobody's going to say that is right what happened to that gentleman. It's like the insulin thing. No one thinks that bread and butter medication like insulin should be available and affordable. Nobody thinks that somebody with a heart attack should pause and think, should I go to the hospital for this? Because I'm a little worried about what this might cost. Right. So it's just wonderful to think in terms of, after the 4 years we've had to sort of start talking in terms of what do we all believe in, and what are the things that we can really get done. I'm going to stick to the cost question. This is just a broader question. What will you do as a member of Congress to lower the cost of healthcare?
So I think, zooming out, cost in healthcare doesn't exist in isolation. The traditional teaching is there's this eternal triangle of healthcare. You probably know where I'm going with this, but it's access, quality, and cost. You can't increase access to care without it having some impact on the cost of care. You can't improve the quality of care without it having an impact on the cost. You can't lower the cost of care without it impacting access and quality. So those are all things that we're always keeping in mind. We must lower the cost of healthcare. We must. And that cost is to different people. Sometimes that cost of care is to patients. So our first responsibility is to lower the cost of care to patients. Some of that's in our relationships with insurers and with our payers, so that they're making sure that patients aren't on the hook and they're able to, their coverage actually means something. And this is where I think the Affordable Care Act was right. It set a standard for what insurance actually was. And so this is why it's so important to have standards around what insurance is. Because when the gentleman who I was talking about, whose heart attack cost him $60,000, it's because the insurance that he had wasn't the same as that, traditional ACA minimum essential benefits insurance. And so what happened is he's on the hook for more, but he's like, but this is insurance, isn't it? And that's why standardization is so important. And so there are some plans that have been expanding over the last 3 years that I think are very problematic. And it's the short-term limited duration plans. Those short-term plans, even, watchdogs all over the country are saying, hey, these plans, they got red box warnings. These plans do not work well. Consumer advocates say these plans, you don't actually know what's covered and what's not covered. It's called health insurance, but really you're just paying money and you don't know what's going to get you. Now, on the other side, so that was one of the plans that's been propagated over these last 3 years in the interest of choice outside of the ACA markets. There are these other ideas of association health plans where people can come together and create plans. And that's one where even though people were worried about it on the front end, they've actually they haven't deviated far from those standards. And so I think they're performing a little bit better, but it's another place for us to keep our eyes open and say, hey, there's some problems here. And then there's the health reimbursement accounts. Those were 3 of those plans that President Trump really tried to push early on in his administration after the repeal and replace effort failed. I bring those up because when we talk about reducing the cost, we have to start with saying for individuals, insurance has to mean something. It has to mean that it's covering a certain, package of care, and that package of care is reliable. And every single American, every person in this country who says, I have insurance, they know that it covers them when they go to primary care or when they go to the emergency department or when they have a hospitalization or say when they're hospitalized for COVID. And COVID has really shined a light on this in a new and different way. Because you have, yes, 200,000 Americans who died, and it's tragic, from COVID, but you have hundreds of thousands more who've been hospitalized. And as you and I both know, they're not hospitalized for 2 days or 3 days, they're hospitalized for 2 weeks or 3 weeks. And I used to say for years, I would tell folks, they say, I have good insurance, so, I'm not worried. And I say, does your good insurance include a copay for hospitalization? And a lot of times they'll say, yeah, I think so. I think it's like 10%. And I'm like, okay. So if you had an ICU stay for 2 weeks, the cost of that bed is about $2,800 in my area. You had an ICU stay for 2 weeks at the cost of $280 a day. To you personally, after your insurance covered its part, 14 days of that. You ready for that? And folks are like, well, and I'm like, and yes, it could be COVID, it could be a car accident, it could be anything to a healthy person. But it's important for us to understand what insurance actually means. So that's the first part. We have to have that meaningful insurance reform that makes sure that every American consumer knows what they get when they say they have coverage, right? So that's the first part. I think we do need to bring down our costs in care. And so we talked about prescription drugs. That's going to be a big part of it. But in the whole $3.6 trillion, it's about 10% of those costs. Right? So prescription drugs, it affects the end user deeply, but it's not what's driving our costs in care. What's driving our costs in care is hospitals, care, and providers. And so I think that's tough for me to say as a doctor who works in a hospital, that we are the part of the pie that's growing the fastest, that's taking up the most space in terms of our costs in American healthcare. But the way that we address that is we realign the incentives. And so we've lived in this world of fee for service for so long. Do more things, get more money. Do more things, get more money. And in fact, we saw the dominance of that again on display with COVID. Because what we saw was when we stopped doing elective procedures because you couldn't do them under COVID, those were the things that make us our money. And so we stopped doing that. My hospital lost $85 million a month and they had to cut the salaries of every single doctor just to get by. And it was like, well, so without these elective surgeries, we can't survive as a hospital. So the truth is, when you realign incentives and you focus on value and you say, hospitals make their money by achieving outcomes at the most efficient cost possible. What you're doing is you're training providers to say, how can I be more efficient at delivering excellent care? More efficient at excellent care. And for some people, they think back to HMOs and they're just like, isn't that what HMOs are supposed to do? But this is different because that focus on the quality is a key part of it. I think when we realign those incentives, that's our best bet for bending the cost curve, is quality at efficient levels. And it allows hospitals to partner well with communities, because sometimes you have bad health outcomes. We have our heart failure patients who get readmitted within 30 days. And sometimes it's because when they go back home, they don't have the support that's necessary. And we've learned to invest in support for folks while they're in the community to keep them safe at home. Right. And I think that's where hospitals can really make some headway. So again, I'm going to go back to a quote that Donald Trump made in February of 2017, where he said, who knew healthcare could be so complicated? Right. It's incredibly complicated. And I think what frustrates me as somebody who does a lot of work in this space is when I hear really simplistic solutions. Because it's just like, you have to understand how this sector works and all of the different actors in this sector. And my initial response when I was very early in my path in doing health policy work was, well, we should just simplify the system then, right? But it's not actually that easy. You have to say, in the context of what we currently have, how do we make sure that patients have the best deal? Patients are the ones who have to do well first. I think that providers and the providers of care, we have to make sure that they're in a good spot, because that is our access to care. If we drive providers out of business by the reforms that we make, then we hurt patients, we hurt access to care. And so they're also interrelated, but I think you truly do have to understand the policy. Now, does it take a health policy does every member of Congress need to be a health policy expert? The answer is no. I think that's not what I'm suggesting. You don't need 435 health policy experts to pass meaningful health reform, but you need some. You need some people who know exactly what it is, who know how to lead this work. And I think that's where I say, at a time when it's critical, at a time where there's a Supreme Court case that's going up on November 10th that could strike down the entire Affordable Care Act. And if it strikes down the entire Affordable Care Act, then what are we left with? And how do we pick up and move on from there? And who's ready to kind of lead that charge? And how can we have a lot of confidence in that leadership? And that's where a lot of the support from my campaign comes from. It's from folks saying, we're at a critical moment for healthcare. We need real leadership. And we think you can provide some of that. And it's the fact that I talk about building consensus. I talk about how there are both market-based solutions and equitable solutions. I call it free market fairness, right? We can do this in a way that leverages the market and leverages that idea of equity. Those are the goals that we have to bring to the table in this next conversation on healthcare in order to get it right. And I think that we're at a point where our patients can't wait for us to get this right much longer, right? We're running into more and more incredible costs. It's hurting folks every single day, and we've got to move forward.
Just as a quick interlude, I was trying to do a tally of how many healthcare providers are in Congress. I think it's 17 physicians and 2 nurses. Does that sound about right? I mean, of course, being a healthcare provider does not make you a health policy expert, but still, it's a pretty narrow bench that we have. And I think a number of those are super subspecialized physicians who actually, didn't spend a lot of time thinking about thinking broadly on healthcare and thinking specifically of health equity. So it seems like this is the moment where we need to build up this kind of representation in Congress. It feels like, a decade ago, long time ago, but certainly very urgent in this year where healthcare has never been so much on the minds of Americans, and the complexity has grown.
That's right.
And there's,
I have a quick story on that, because when I worked in the White House, it was actually during the months when I worked in the Trump White House, there were, in my White House Fellows class, it was 16 of us total, and 4 of us were physicians. There was a pulmonary and critical care specialist, Dr. Tina Shaw, a neurosurgeon, Dr. Lindsay Ross, and a psychiatrist, Dr. Robert Accordino, and myself. And so between the 4 of us, we were always looking for ways to engage and say, what does it look like to be a doctor in policy and politics, right? And so we reached out to the Doctors Caucus, which was an almost entirely Republican endeavor. And we sat down with the chair of the Doctors Caucus. His name is Dr. Phil Rowe. He's from Tennessee. And he was joking. He's like, I'm just an old country doctor. That was who he was. He's very much so that like Marcus Welby type primary care doctor. But what was great was he's a Republican member of Congress in the House. But when we sat down, we were all just doctors. We were talking about a healthcare system. You couldn't see any kind of political, ideological division between us because we were talking about patients that we care for in like rural communities and the care that they need in a primary care space. And you weren't hearing that hyperpartisanship. And it struck me right then and there. I was just like, I could sit down and talk with Phil Rowe all day, every day about healthcare, and we're going to be head nodding and saying, that's right, that's what's happening in healthcare. I think sometimes politics gets in the way when you start thinking about ideology. But when it comes to doing what's in the best interest of patients, we do have a huge opportunity. And so you're right about what the number of positions in Congress. Of those 17, there are 3 Democrats. So it's Representative Kim Schreier in Washington, and then 2 from California, Ami Bera and Raul Ruiz. And I think I've had the opportunity to get to know them and talk to them about kind of their service and what that looks like. And you realize how often they're called upon to bring that expertise and bring that leadership. And I also realized that very few of the physicians in Congress were directors of health policy or had health policy experience beforehand, or were on state boards even. I think that there's an expertise that I bring that I think is a little different. And no, we don't need all policy wonks in Congress, but we need a few because we need to get some. We need to get it right. We need to have some real leadership.
Yeah, and spread that, kind of spread that responsibility around, and not just have such a thin bench. I'm going to stay on cost. Do you feel beat up about cost, or can we stay on cost for one more?
We can do
another question.
I don't feel beat up about it because that's the issue, right? I mean, you can talk about a lot of things, but cost is what is moving people. It's what's on people's minds. So let's stick with it.
And I love it. And it's for what you said, and also this one specifically about Charlottesville. And so I wanted to make sure and that person got their question in. So it says Charlottesville has one of the most expensive rates for healthcare in the United States under government plans, up to $15,000 deductibles, as much as $2,000 per month for a couple. This results because Virginia's Insurance Bureau allows Optima Centra to charge high rates. How will you fix this?
This question it feels like it's my friends from Charlottesville for reasonable health care. But I think the reality is that, in 2018, the highest insurance premiums in the entire market across the country were right here in Charlottesville now. So it was an incredible moment where in this 5th congressional district, folks were facing the highest costs. And if you're paying close attention, the people who were hurt the most by this are the folks who were buying their insurance in the marketplace, but who weren't subsidized. So that means they were above 400% of the federal poverty line. And for those individuals, they're feeling the full cost of this health insurance. What I think you had to do to fix this was recognize that the ACA, when it was passed, it had some flaws. And because of the fight over the ACA ever since March 23rd, 2010, there's never been an opportunity to go back and make even those simple legislative fixes that any type of legislation typically has, let alone landmark, huge sector-changing legislation like the ACA. So there's something called the family glitch, where your rates are set based on an individual as opposed to a family. We never got to fix that because there's no way to get that passed through our Congress. There are things like, and you can talk about what you do next in those insurance marketplaces, extending the subsidies beyond 400% federal poverty line. Once the Trump administration started, we got rid of the cost sharing reduction subsidies, and that had a huge impact. You go back, I feel like it was I think it was a $25 million judgment that was in front of the courts because or it might have been more than that, but it was health insurers were saying we never got paid for care we provided, and I think that was a huge challenge, and it was one of those flaws in the funding mechanisms for the ACA because politics got involved. Once you had a change in the party, a lot of things were impacted. There, the appropriations process, you weren't seeing the money going into the places where it needed to go to keep that law afloat. On the front end of the Affordable Care Act, you said there are 3 things that you need for insurance companies to keep those costs low. We call them the 3 R's, not reading, writing, and arithmetic, but it was risk adjustment, risk corridors, and reinsurance. And those are 3 dynamics that we know from Republican legislation, from Medicare Part D that help keep the costs low for insurers because there's predictability when they're taking on new risk. Insurance is all about risk, right? And so there's a lot that we can do to fix some of those elements and fix the cost challenges that folks are facing. But politics right now is getting in the way. And I think that if we put the American individual, the American patient at the center point of what we do next, and we talk about how can we solve this for American patients, I want to be clear. You've heard me talk about the free market lots of times, but I can tell you with 100% certainty, the market alone cannot fix American healthcare. It cannot, because it's not, and I think I've had this conversation with so many conservatives, and they're just like, here we go. You're going to say it's not a normal market, right? And I'm like, it's not a normal market. There's a asymmetry of information, right? A patient isn't your typical consumer. They don't walk into that space and say, actually, you know, what I think I'm having is a heart attack, and I'm willing to pay $20,000 for it. I'm not willing to go up to $40K. And in fact, with this heart attack, I'm going to go down the street to the next hospital. Like you can't expect that it's going to operate that way. And I think that you have that part. You have you have the insurance company that's in between the provider and the patient, and so you have somebody else who's kind of doing that negotiation on somebody's behalf. There's so many things that make it an abnormal market. I give credit to the Trump administration with some of their price transparency work, because that's huge. That has the potential to really transform healthcare. We need that transparency, because it creates an accountability. And I have a lot of faith in the American people to say, you know, yes, now that hospitals all had to publish their charge master, you can say, okay, somebody's going to figure out how to make sure that that information is useful and usable. If you've ever looked at a charge master, it's like reading hieroglyphics. So it's not usable right now, but the hope is that somebody can take advantage of that. It's going to be a combination of these solutions, but ultimately you're going to need a combination of the market and government to get healthcare right, to bring down those costs. And to your question, here in Charlottesville, it was the fact that we had an unopposed monopoly. There was a single insurer in the marketplace because of factors that forced other insurers out. They weren't getting paid. And so somebody stepped in and said, well, now I can charge whatever I want. And what was interesting is the very next year, they were again set to charge really high prices. Another insurer came in and they were like, oh, actually, we don't need to charge that much. We can go lower. Because that's what a market does. If you're unopposed, you're going to extract your pound of flesh. You're going to make as much money as you can in any given market, because that's what markets do. Right. So you have to have that idea of competition. That's where public option is also helpful, because its presence on a market in every health insurance presence on a market helps to say that, hey, you're competing against something. It's not going to be these unopposed prices.
You're never unopposed, right? You're never unopposed.
That's important.
I love it. All right, so I do have one other question, but I also I just want to leave room for questions from listeners too. So I'll ask mine, but certainly welcome de novo questions to drop into the chat. So this is not about cost. You'll be shocked. This says, what actions are we taking to increase medical literacy in our community, or what actions can we take to increase medical literacy?
Yeah, there are a lot of dynamics that go into health literacy or medical literacy. It's a different thing than literacy generally, but there's a relationship between them. So I think our investment in education is part of our health literacy conversation as well. But I think that also one of the big challenges is the nature of what primary care looks like. And my story is that I did a primary care training program in residency, but then decided to go into hospitalist inpatient medicine, because while it's busy and it's crazy, few things are as crazy as primary care, in terms of the churn and the fact that you're always there. You got to see another 15 patients really quick. You don't have that time to build. I actually remember I got into medicine because I love building relationships with people. And I remember the moment when I recognized that I got to build more meaningful relationships, even though they were over a shorter duration, by being an inpatient provider, because I'm meeting that patient and their families, and we're together for a week or 2 weeks, however long I'm on service, and I'm actually getting to build with them, right? In primary care space, I felt like it was just like in the door, and I'm like, I got another patient who's ready for me right now, and you're always running. I bring that up because there are a lot of pressures that create that dynamic, but so often when we've looked in the literature about health literacy, folks will tell the doctor will say, do you understand what I'm telling you? And there's a pressure on patients to be like, yes. But if you go in right afterward and you say, did you understand what those goals, what those recommendations were? The answer is no. So I think somehow kind of unpacking that really tight, pressure-driven, fee-for-service primary care space is important. And here's what one of my colleagues from the Trump White House, her name is Katie Talento. She was the director of health policy in the Domestic Policy Council. And now she does a lot of work in kind of the direct primary care space. And it's interesting because, for conservatives, they look at direct primary care and they're like, that's a great innovation in healthcare. People pay a subscription fee and they get all the care that they need. Doctors have more time with patients and people like the care that they're getting better. And Katie and I talk about this, we still talk regularly, and Katie and I talk about this, and she's just like, there's a space for DPC, direct primary care, no matter what the healthcare system is. And I'm like, you're right. But every primary care space should feel like people have the time and the attention of their provider. And how are we working toward that, right? And I think that, and so it's not to say we should move away from direct primary care. I know some direct primary care providers here in this area who are doing really important work. But I think that it reminds us of just the truth that we should be striving for primary care spaces where you can engage, and so that patients are getting the information necessary to take control of their health. Right? They shouldn't be left to search for it on Google and try to figure it out on their own. That's what that space is supposed to be for. And then I think that's the other thing I'll talk about is navigators, community health workers, some of those other dynamics, those other components that are huge. And that's part of that public health apparatus that's so important to invest in, and sometimes that we lose the funding for that the fastest. There was some money for public health in the ACA, but Democrats cut that funding first, and then Republicans cut it too, and everybody always takes their eye off the ball when we're talking about investing in public health and preparedness. We're facing kind of the downside of that now, when we didn't invest in public health and preparedness, and now we have a pandemic that we weren't prepared for. But I think a big part of it is making sure we're investing in the things around healthcare that give people opportunities to understand and take control of their health.
Yeah, I'm really feeling that comment. One last question, then I think we're at time and we'll need to start wrapping up. From Jeff Ritter, what are your thoughts on universal catastrophic coverage with premium scaled to income, free below a threshold income level?
Yeah, Jeff, I love the concept. I think when you say catastrophic coverage, I think it just depends on what we define as catastrophic. I think, so my thought is everybody should have health insurance that's actually meaningful. Catastrophic, the ball has moved on what that's meant over years because the cost of care has increased so much. But one thing that I've heard from conservatives is this idea of universal catastrophic coverage, but also health savings accounts that help fill the gap between it. It's one of the innovations. I suspect it's going to be one of the points of negotiation, is that if you create a public option, what's the level of coverage? What's the, is it catastrophic in nature, which would be a plan that doesn't meet the ACA's minimum essential benefits requirements, but only covers extreme costs of care, like if you had an accident or a COVID ICU admission or something along those lines. I think that in terms of the safety and security and well-being of folks, catastrophic coverage alone doesn't really feel like coverage. There is, I'm sorry, I have 2 young kids, so I live my life through Disney movies. But in Return of Jafar, they say you'd be surprised what you can live through, right? There are some moments that seem catastrophic, but are technically sub-catastrophic in definition, but are an extreme cost to a family. And so I like the fact that you incorporated the premium thresholds, because I think that helps address the cost on the front end. But again, I think it really comes down to what's just short of a catastrophe. What you're describing reminds me of the Part D donut hole in Medicare prescription drug benefit, and that there are people who are like, well, I have catastrophic coverage for prescription drugs, and my first dollars are covered, but man, just before they got to catastrophic, people were paying thousands of dollars, and that would become your new crisis. And so I think you have what we have to strive for is everybody having real coverage that covers the range of things that people need. And I would classify that as a catastrophe, right? If you have a healthcare admission, that's a catastrophe. It's upsetting your life. It's taking you out of spaces where you're able to work. It's doing a lot of damage. I don't want government saying, well, catastrophe is actually if you have to spend $30,000 or more, or $20,000 or more on an admission. I think that we should really strive to have a definition of what meaningful insurance is. So I like some of the concepts in there in terms of the cost of the premium and how that's indexed to income. I think you're spot on with that. In terms of the nature of the coverage, I would aim to do a little bit better than catastrophic, and that's for a public plan. And I think that's what you'd aim for in private spaces as well.
Okay, thanks for that question. And unfortunately, we're at time. So I wanted to wrap up first, and then I'll leave the floor to Cameron. But I was trying to do this. I was kind of making an old school word cloud while I was talking to you, which conceptually I thought was a good idea. Now I'm like, there's nothing visual to show, but I'll read aloud some of the things that I wrote down in all caps and then just kept circling as we were talking. I just kept on hearing consensus and commonality. I heard the word innovation a ton. I wrote down market aware health equity. Okay. Get politics out of the way. I wrote depth of understanding, big picture, but also granularity. I wrote high value, standardization, transparency, accountability, and patience in the public first. Those are kind of like my big words for you. And I think what really rose to the surface is these are things all Americans want, all Virginians want. And I just continue to find you so inspiring and just really focused on making the world a better place and a livable place and a place where you can have a high quality of life. I'm just so excited to be here tonight. And I'm going to wrap up by saying, please check out his website. It's drcameronwebb.com, and his Twitter account is also Dr. Cameron Webb. Please check out the rest of his platform that we didn't get to. Sign up to volunteer. There's still time. Early voting starts tomorrow, so let's get people registered to vote and get their early votes in. Donate if you're able. We know it's a tough time, but even the $5, $10, $20, it adds up. And if you post your donation receipt under his Twitter account, either his campaign or his personal Twitter account, and I see that receipt tonight up till midnight on the West Coast, just to give it extra time, I will be matching those up to $200. So please make a donation to the campaign tonight, and if you can't, spread the word about this outstanding candidate and support in any way that you can. But thank you all for attending. It was such a pleasure to be here, and Cameron, it was just such an amazingly fast and fascinating hour for me. So thank you for this opportunity.
Well, thank you so much for taking out time from your schedule to moderate and just join me in this conversation. As folks can tell, I know this issue with a level of depth that I think is important. And yes, sometimes I get into the weeds, but it's because I'm passionate about it. I'm passionate about fixing healthcare in a way that really works for people, that works for our society. And I think that it's not the kind of thing that fits into a 3-word phrase or a nice little slogan. It's the kind of thing that's big and complex and unruly, just like our healthcare system is. And so I'm so glad we were able to take an hour to just scratch the surface of this. And we'll continue to have this conversation. I'm always willing and ready to have this conversation with folks every single day. But I'm also excited to have conversations of similar depth about education, about rural broadband, about climate change, about policing, all of the issues that we're facing. Again, it's not about a slogan. It's about making sure that we understand the policies that we're up against, and we're sending leadership that can represent the spaces where we are. I know that I'd be a passionate advocate for the folks in the 5th District. I know that what they'd get from me in the healthcare space is something they'd be really proud of. And so, like I said, really grateful for you for taking out some time. Really grateful for everybody who tuned in, who listened to my nerdy answers about healthcare. But at the end of the day, sometimes you need to bring that kind of expertise to address the most challenging issues in front of us. So thank you all for taking out an hour of your time. Let's keep the conversation going. 47 days left until this election, and you have an important choice to make at all levels of the ballot. And so please do your homework. Make sure you know who you support. I hope that you'll consider, if you're here in the 5th Congressional District, you'll consider supporting me for United States Congress. I hope that what you've heard tonight tells you that I'm the kind of person who's going to be passionately having your back in the halls of Congress. But at the end of the day, if you have questions, send them my way. Thanks for the support. Thanks for the love, and have a wonderful night. Y'all take care.
Good night, everyone.